We are live.
Good evening. I welcome everyone to today's iFocus online session. So today we're running in the cataract module, and today's episode is 419, episode number 419. Today we have Dr. Kanika ma'am as our speaker to talk on evolution of cataract surgery, and we have Dr. Kiran ma'am to moderate today's class. She ma'am has done her MBBS from BJ Medical College, Ahmedabad, and her MS from MNG Eye Institute Civil Hospital, Ahmedabad again, where she received gold medal. She has done a senior residency from DDU Hospital, New Delhi. She is currently working as a senior consultant at Center for Sight Eye Hospital, New Delhi. She's a trained and certified femtocataract surgeon and a refractive surgeon. She's been an organizing secretary of prestigious PG training program iFocus and also organizing secretary of IIRSI. She's a faculty in iFocus, IIRSI, and various other conferences. She has authored book chapters and publications in index journals. So over to you, Dr. Kiran ma'am, for introduction of our speaker, Dr. Kanika ma'am, and our chairperson, Dr. Rishi Mohan sir.
Thank you very much, Dr. Kritika. So we have Dr. Kanika today. Can we go to the next slide, please, Dr. Kritika?
Yes, ma'am.
Okay. We'll be having a session by Dr. Kanika, and she'll be speaking on evolution of cataract surgery. But first, I would like to introduce our chairperson for the day, Dr. Rishi Mohan. Sir has done his MBBS from MAMC, New Delhi in 1982 with a gold medal, and MD in ophthalmology from RP Center in 1985. He did his DNB in 1986, followed by senior residency at AIMS in Cataract and Cornea. Having done his fellowship with Project Orbis Inc. USA as staff ophthalmologist in 1989, Sir also did a clinical registrarship in Prince Charles Eye Unit, KE7 Hospital, UK. He's done fellowship of the Royal College of Surgeons of Edinburgh in 1996, awarded membership of Academy of Medical Sciences 2006. Sir has been a recipient of various academic awards, including the Maulana Azad Medical College Gold Medal and Certificate of Merit for First Position, the Best Resident Award for RP Center for Ophthalmic Sciences in AIMS 1986. Sir has been holding various prestigious positions all across the country. He's been the member of Scientific Committee IOS 1996 to 99 and 2009 to 12. He's been secretary of the Indian Society of Cornea and Refractive Surgery, Joint Secretary ABI 2013 to 15, and he has been the president of DOS, Delhi Ophthalmic Society, from 2016 to 2017. Sir is medical director and chief cornea consultant at MMI Institute, a unit of Center for Sight, New Delhi. So coming to Kanika, introducing our speaker, our young, enthusiastic, bubbling speaker. Dr. Kanika has done her MBBS from Government College Mohan Kumar Mangalam Medical College, Salem, her DNB of Thalys from Eye Care Eye Hospital and Institute, Noida, and she's done her fellowship in cataract and refractive surgery from Center for Sight Eye Institute, New Delhi. She's currently an associate consultant in Center for Sight in cataract and refractive surgery. She's involved actively in the training of DNB and PG students and has been mentoring fellows. She's a recipient of multiple awards for Best Video, Best Paper, Best Poster at AIOS, DOS, Women Ophthalmic Society, SAO, and various conferences. She's been a recipient of Young Researchers Award for her thesis. She has multiple publications on cornea, cataract, and refractive procedures in various national and international journals. So before Kanika starts and embarks on her journey explaining to us how the surgery evolved, I would request Rishi sir to speak a few words and introduce the topic to us.
Well, thank you so much, Dr. Kritika. Again, welcome to all for this session. Dr. Kanika, of course, is going to tell us all about cataract surgery. In fact, this whole module is on cataract surgery. And this is the talk that could have happened right in the beginning. But she's going to tell us all about how cataract surgery has evolved. I think it is important to know the history of how cataract surgery has moved from very, very ancient periods. Cataracts were defined and described thousands of years ago in texts. And I think where we are now is very, very different from where you used to be. In fact, even when I was training 25, 30 years ago, there's been a sea change in the way we look at cataract now. And the evolution from just taking the lens out to make it a restoration of vision procedure to something that actually adjusts the refractive error is again a big change in the way we look at cataract surgery. So without any further delay, I'll hand you over to Dr. Kanika. You're muted, Dr. Kanika.
Thank you, sir. So without further delay, I would like to move on with this interesting topic. Today's class is more of a class with historical perspective than an academic touch to it. The reason why we need to study the evolution of cataract surgery is because unless we know our past, we cannot define the future, and that's why the generation presently, they should know how it came to be. And it is only in the 20th century that actually ophthalmology has flourished and cataract surgery has become what it is in the modern day. Prior to that, a lot of other things were happening, and this present session intends to just acquaint the students and people watching this video that what all happened and long ago. So a brief history. What happened is mentioned even in the ancient scripts of Babylon, where first references to the eyes were made in the Code of Hammurabi. It was in 1550 before Christ that eye diseases were also recorded in the papyrus in ancient Egypt. However, the most important and significant contribution to ophthalmology or cataract surgery per se is from ancient Indian times, that is by Sushruta, who's also known as the father of surgery. So Sushruta in his Sushrut Samhita had written a full chapter on eyes by the name of Uttara Tantra, which is about 500 years before Christ. And that's when the idea of a surgery for cataract or a development or a maldevelopment in the eye was developed. Following this, there have also been some scriptures in ancient Greek where they have mentioned about dissection of the body and also eyes. There have also been records where Alexander the Great, when he visited India, and in those times during his quest, he also came across Sushruta, and that surgical procedure that Sushruta was following at that time was taken back to Greece and other part of Europe. Following this, there was quite a quiet era where not much was done, and for a long period of time, couching or the ancient technology was only used. The golden age of ophthalmology was somewhere around in the 19th century when various devices were developed which could see inside the eye. And the modern day cataract surgery, as we know, is basically attributed to the 20th century. So what are the types of cataract surgery? Like I said, during Sushrut's time, it started with couching. So couching by itself, this word means to put to bed. So this basically involved putting the lens down into the vitreous in a position of rest. So therefore, this name couching came into place, where a needle used to displace the zonular fibers and therefore detach the lens, and it was dropped into the posterior segment. Following couching, it was in early 18th century and 17th century late when the lens was tried to be extracted through an extracapsular cataract extraction. This involved a larger tunnel, and it was successful to an extent, but not very popular. And even then, the couching process was only followed. A few years later, intracapsular cataract extraction was popularized. Coincidentally, ICC got more popularity than ECC, but it was only later that people realized and ECC came back into vogue. It was a groundbreaking invention by Dr. Kelman in 1967 with the invent of phacoemulsification that actually the modern day surgery started its fast pace. Nowadays, we also have manual small incision cataract surgery and micro incision cataract surgery, and not to forget the latest, the femto laser assisted cataract surgery. We'll go through those one by one. So this is a basic historical representation how cataract surgery techniques have progressed over the years. It started from couching, and for a long period of time, couching was the main process which was followed. Even today, in the remotest parts of the world where there is no access to medical technologies, couching is also performed. Latest techniques, like we said, was only after the invention of phacoemulsification by Kelman in 1967. So basically, it was the 20th century that actually saw development of cataract surgical practice. Going back to 2000 years before Christ, it was during the reign of Hammurabi, the king of Babylon, that the mention was made. And there was also a reward for any physician who would make a wound, and with using a bronze lancet, he would open an abscess in the eye. So cataract in those times was referred as an abscess in the eye, and anybody who could relieve the person of the abscess was given a reward. At that time, it was also thought to be an extension of an abscess in the brain. Then came Sushruta, an earliest form of surgery around 200 to 300 years before Christ, by the name of couching. So this is Sushrut with his instruments. These instruments are what have been written in a book, Sushrut Samhita, and we can see the triangular needle and also the lancets for couching here. And the modern day needles are also quite similar to these if we actually pay attention to them. But this is a video of how couching was performed. Basically, a sharp instrument or a blunt instrument is introduced close to the limbus, and it is rotated all around the lens in such a fashion so that the zonules are displaced. The instrument pushes the lens backward so that the pupillary area is devoid of the opacity and some light can enter. Of course, couching was not very successful, and half of the time, and even 70% of the time, it led to serious complications like glaucoma and even blindness. But it was still considered a preferred choice, considering it used to let some light enter the eye. Also, people in the remote areas still believe in these old practices rather than believing on modern science surgeries. Then came ECC. Now, this was a very big development because it was Jacques Daville. He was a French ophthalmologist. In 1747, he first performed an extracapsular cataract procedure. Basically, he was the first one who put an incision on cornea, although his incision was very large, about 10 to 12 millimeters in length. He also proved that, opposing the current thought at that particular time, that vision loss is related to the opacity of the lens, and it is not because of some bad body humors or ailments of the body. ECC initially was not popular a lot. Daville actually would aspirate the lens material out, and he would do some curating in the capsular bag, which would lead to most of the times incomplete removal of the cataract opacities and secondary glaucomas. And disturbance in the lens material also led to some infections. So it was not very popular at that time. It was later when we had modern tools like foldable intraocular lenses that came into picture that ECC was again popularized. ICC, or intracapsular cataract extraction. It was Samuel Sharp in London who first performed the intracapsular cataract extraction. He made a large limbal incision and he removed the whole lens together with the capsule. So this was actually a modified form where instead of dislodging the lens into the posterior vitreous after dissecting the zonular complex, the lens was actually extracted out of the bag. So for about 100 years, almost, the ICC was the method of choice in cataract surgery. It involved a large incision on the limbus and just taking out all of the lens as well as its capsule outside. Now, relatively, obviously, there was a loss of vitreous and a lot of complications relating to retinal detachment. So in those times where nothing else was available, this was only performed. It was only in 1961 that a Polish ophthalmologist, Krowitz, he invented cryo-extraction. So instead of using sharp instruments to dislocate the lens and take it out, the cryo-extraction technique was used, which used a freezing probe in order to remove the cataractous lens. This was less traumatic as compared to the original technique of Samuel, in which he also used his thumb to express out the lens and capsular complex. So this is one of the pictures in ancient documentation where they show how an ICC was performed. So they used the single knife to cut a long incision and separate the zonules and the bag complex. And opposite thumb expression was used to extract the whole of the complex out. So this is another video. This shows how the cryo extraction was performed. So once we enter the chamber, the cryo probe is introduced. A safety suture is applied. So once the lens surface is dried for the probe to get into contact and stick to the lens, then the cryo extraction is performed. So we can see here, the probe gets a good hold of the nucleus and the whole of the nucleus is extracted. So even cryo extraction was a very popular procedure, but like we already discussed, loss of vitreous and other complications made ICC less popular in the long run. Also, with the advent of better techniques like viscoelastics and also intraocular lenses, foldable intraocular lenses, better surgical practices came into being. This is our mentor, Dr. Mahipal sir himself, performing one of the cryo extractions in the earlier times. Post all this duration, ECC again made a comeback, and it was with the help of Dr. Harold Ridley that ECC got more popularized with the advent of intraocular lenses. In between, there was also a technique which was a modified form of ECC called small incision cataract surgery. Now, small incision cataract surgery is relatively new to the picture. It was only developed like a few decades ago. So, in manual small incision cataract surgery, what happens is instead of a clear corneal open incision, there's a self-sealing scleral tunnel incision. So considering it doesn't require much of high-end devices, this is a low cost and basically it is performed in the developing world. This is very commonly performed even today in most of the camp areas or the underprivileged areas where there is not a good access to latest advanced technology. Shorter operative time, less need for technology, and lower cost make this a very popular options in most of the developing nations. So manual small incision cataract surgery, the first mention of small incision cataract surgery was by Blumenthal in 1992, where he described a modified technique of manual ECC using the help of an AC maintainer. Now, because of the AC maintainer, the chamber was maintained very well. And he introduced a glide into the anterior chamber behind the nucleus, and he used to give some external pressure along with hydroexpression to deliver the nucleus. So grossly, this was also a tunnel incision, but it was not. It was not until 1999 when modern day SICS came into being, and this was actually described by Root et al. Dr. Root or Dr. Sandup Root is a Nepali ophthalmologist. He was born in 1954 in a very remote village in Nepal. And the whole purpose of his life has been to deliver a low cost and best technique with no post-operative complications to the most underprivileged areas. He is also referred to as God of Sight. He has treated millions of underprivileged people in remote areas of Africa and Asia. He actually developed SICS along with his mentor, Dr. Fred Hollow, who was an Australian ophthalmologist who was visiting him during his formative years in 1980s in Nepal. So combinedly, they have also opened one of the institutes in Kathmandu, Nepal, by the name of Tilganga Eye Institute. And it's a very big institute and it caters to lakhs of surgeries every year. So there's also a book on him. So it's a very inspiring book to read. This is how modern day SICS is performed. So from the ancient 10, 12 millimeters of large incisions with the open wounds, now we have come to self-sealing tunnels. And of course, smaller incisions than even the SICs. So after performing a peritomy, an external scleral incision is made 2 millimeters from the limbus. The tunnel is dissected. Now the tunnel is mostly triplanar, that is, there are three planes, one in the sclera, one in the limbus, and one in the cornea. The internal lip or the corneal lip is kept larger to accommodate the nucleus and hasten and support its delivery outside. So this is the keratome, opening up the tunnel and extending the incision. Capsulorhexis being performed. Sorry. This is using a Utrata forceps. And hydrodissection is carried out to separate the nucleus bulk from the capsular bag. It is relaxed into the anterior chamber, rotated, and delivered. Now, there are multiple techniques that have been advised. The initial technique by Ruiz et al. Included a triangular capsulotomy to facilitate the nucleus being delivered. They also used irrigating vectors or even a fish hook technique and a sandwich technique to deliver. There is also a viscodissection technique that can be used. So there are multiple developments over the years, even in nucleus delivery in the SICS technique. Post nucleus delivery, the remaining cortex is aspirated and then intraocular lens can be easily implanted in the back. Now, because this is a self-sealing scleral tunnel, it doesn't need sutures. So very effective for the developing areas where there is not a good access to the modern day advanced surgery. Even it has been noted in recent studies that a good manual small incision cataract surgery gives equal results as a good phacoemulsification surgery. Now, coming to the modern day cataract surgery, in 1967, Charles Kellman was the first who introduced the method of phacoemulsification, in which he used the energy of ultrasound to crush the lens and remove it from the eye through a 3 millimeter incision. So from a 7 to 8 millimeter incision in SICS, we then move forward to a smaller incision of 3 millimeters in phacoemulsification. The present time surgeries have incision length even less than 2 millimeters, that is 1.8 millimeters. It was the combination of introduction of phacoemulsification and artificial lens, and also use of topical anesthetics by Fishman in 1993, that all these three together came and now are now known as the modern day cataract surgery. It was on 8 February 1950 that the first IOL was implanted in St. Thomas Hospital, London, and this was by the efforts of Harold Lidley. So in phacoemulsification, the lens is broken down into smaller pieces through a smaller opening, and then after emulsification, it is taken out and artificial lens is placed. Just the imagination of this concept itself, by itself, is a big contribution to the ophthalmology world, and we are indebted to Dr. Kelvin. So this is Sir Harold Ridley. He was actually an ophthalmologist, and he was treating the army veterans and army commanders during the Second World War. And what he observed was that during the procedures, the pilots who had suffered eye injuries from the shattered windscreen of their airplanes, that was basically a plastic material, they had no inflammation even after retaining the plastic material into the eye. So this prompted him to search for the material. Basically, the plastic material, which was actually a derivative of acrylate, did not incite any inflammation or immune reaction in the eye. So this is what prompted him to search for a possibility of an intraocular implant. Initially, in his days, he was actually opposed by a lot of the community because they did not support the introduction of a foreign material into the eye. However, with time, of course, and with betterment of techniques, this technique of intraocular implantation has grown not only better, but one of the best inventions in cataract surgery so far. The first IOL was implanted by Rayner and Ridley, and the first IOL was actually manufactured by Rayner. So this was performed in USA in 1952, but in London, they had already done it by 1989. There is also a plaque at the St. Thomas Hospital, London, which was recently established in 2001, which mentions the first intraocular lens for the treatment of cataract implanted by Mr. Harold Ridley. The first FDA-approved lenses, in fact, which was choice lenses, they were also manufactured by Rayner. Now, present-day IOLs have come a far way from what they were initially. The intraocular lens design can be single piece or en bloc or a plate haptic, open haptic. It can be angulated or planar. So we can see here, these are angle supported lenses. These are iris fixated lenses. This is a plate haptic, considering the haptics appear like a plate, a broad plate like structure. These are the loop haptics. This is angulator haptics, which would prevent optic capture and also development of posterior capsular opacification. The three-piece lenses initially would have J loops now, which have been modified into modified J, and presently the models that we use have C loops in them. This is another detailed description of the various haptic designs. So there is modified C loop and J loop and also plate haptic models available right now. Now, the haptic material is usually polymethyl methacrylate. This is a derivative of an acrylate. They can also be polyimide or elastomide, and they can also be polyvinylidene fluoride. So all of these have good material memory, and hence they are more suitable. The single piece IOL nowadays is actually a version of a hydrophobic acrylic foldable IOL. The silicon IOLs, which were introduced in intermediate time, were not very popular, considering they had more inflammations. So they are now not preferred. The modern day single piece IOLs are actually acrylic material. So in India, the pioneering work in phaco was also heralded by our mentor, Dr. Mahipal Sachdev. He's also written the first book on phacoemulsification. So this is how the phaco works through a 3 millimeter. Mostly it is a 2.8 millimeter or 3 millimeter or 3.2 millimeter incision through which we can emulsify the cataract by chopping it into smaller pieces. There are micro instruments which can help disassemble the nucleus, and then one by one it can be emulsified and taken out. And through the same incision, a foldable lens can then be implanted, giving the modern day surgery its name, that is the refractive surgery now. We can also calculate lenses so efficiently with the advent of modern day formulas and biometers that cataract surgery now is actually considered a part of refractive surgery. So in another example, we can see even a hard cataract can be operated through phacoemulsification. Of course, there are certain concerns about the corneal endothelial damage. So even a modern day SICS is a good option for these hard cataracts, where the surgeon is not very confident with phacoemulsification, or if the energy utilized is too high. This is how a dense brown-black cataract is being emulsified in the bag with the help of the probe and a chopper. So of course, at the end, we can implant a lens into the bag. So the modern day cataract surgery basically preserves all of the anatomy of the cornea and the lens and the zonular complex with minimal disturbance to the anatomy and a good outcome. So after the phacoemulsification, next came the big jump. So there's a saying that don't be afraid to take a big step because you can't cross in two small jumps. So femtolaser assisted cataract surgery is the one that is the latest technology available. It is a simple, effortless surgery which can even make the complex of all scenarios into a piece of cake. So femtolaser assisted cataract surgery was approved by the United States FDA in 2010. And it has ultra fast pulses in the range of 10 to power minus 15, which require less energy as compared to the ultrasonic probe of the phacoemulsification for tissue destruction. Originally, the femtolaser was not invented for use in ophthalmology. It was basically used to embed various metallic chips and to devise various bioprosthetic devices, even used in production of stents and other things. But it was because of the cold ablation pattern of the femtolaser that it was then later applied to eye as well. So it is basically a highly focused energy beam which creates plasma at the level where it is focused. And this plasma of free electrons and ionized molecules rapidly expands, creating cavitation bubbles. And this force of cavitation separates the tissue. So basically, a femtolaser is a cold ablation. That is, it doesn't cause damage to the nearby areas. So this is basically derived from a magazine on the metallics. So we can see on the left side with long pulse lasers, we can see that the wavelength being larger, they have an area where there is maximum heat and an adjoining area where the heat can affect the tissue that has been exposed. But with the ultra short pulses in the form of femtolaser, no collateral damage is seen. And hence, this is very aptly applied to various structures of the eye because the pulse range is infrared range. So there is no absorption by the cornea, and hence it is not harmful to the cornea also. So this is how a femto docking looks like. Basically, it consists of a cup wherein fluid interface is there and the eye is positioned into its place and locked into position using suction. So this is how it looks once the lock is placed. Then there is an integral scanning system which can scan the capsule, the cornea, the lens, the anterior chamber, and even some part of the anterior segment. It can also give us an information about the posterior capsule. If we see any dehiscence or discontinuity in the posterior capsule, we can easily shift the posterior cuts to a level where we can have a safety cushion. Regarding the nucleus, it can help us in softening the nucleus by making smaller pieces of it. It can also give us a good, well-centered capsulorhexis and can also help in making limbal relaxing incisions and corneal incisions. So this is how femtolaser assists in the hardest of cataracts. So we can see how easy the capsulorhexis has been. And these are the cavitation bubbles which are released once the hydrodissection procedure is carried out. The cavitation bubbles by themselves actually cleave the nucleus in various planes. So we can see here how hard this nucleus is. This is nucleus sclerosis grade 5. So with the help of femtolaser assisted cataract surgery, even such hard cataracts can be done very easily. The video is courtesy Dr. Maipal sir. Another case where we can utilize the softening procedure of the femtolaser to divide the nucleus into smaller pieces. So we can make various pieces and we can make various quadrants and even 6 or 8 parts to the nucleus as per our requirement. And here what we see here, the small corneal incision here, this is actually the LRI or the limbal relaxing incision that the platform helps us make. So we can even treat astigmatism of the patient while performing the cataract surgery, even if the astigmatism is not high and doesn't require a toric lens. A femtolaser can very well help in that. So this is how the nucleus is chopped into multiple smaller pieces and it helps deliver lesser energy to the corneal endothelium and better recovery. And we can even place good multifocal lenses with this. So this is basically a prototype of the modern day cataract surgery with a multifocal in place, femtolaser utilized for the process, and also a astigmatic correction using the LRI. So this is again how a femto docking platform looks, and you can notice here that the lens tilt. So in cases of subluxated or decentered cataracts, this anterior segment imaging can give us a good clue, and we can plan our rhexis and capsulotomy accordingly. And also we can be a little bit more cautious during our surgery when it involves operating on such dislocated lenses. So we have come a long way, right from the age of couching to then ECC, then ICC, ECC, phacoemulsification, and present times we have femtolaser assisted cataract surgery. So this is how times have progressed, but please note that for a longer period of time, there was no development in ophthalmology. It was only in the 20th century that actual growth and progress happened. So it is basically very fresh, and hence it is important for us to know how things have been progressing so that we can go ahead and build an even stronger future. Now, IOLs or the intraocular lenses have also adapted along the way, along with the cataract surgery techniques. So the first generation Ridley IOLs, as we know, they were just pieces of acrylate and large bulky ones, not very well supported. And hence, it was after that that generation 2 anterior chamber intraocular lenses were introduced. They had larger plate haptics. Then in 1950s, there were generation 3 iris supported lenses, Wurst and other lenses. So these were basically implanted and supported by the lens. They had small nicks where the iris tissue could be captured. Then in 1960s and up to 92s, there was ACL, the generation 4 anterior chamber IOLs, which were measured according to the cornea, and they were actually angulated and a little haptic was, and the optic was elevated a little so that it could be positioned well. Then came the generation 5th lenses, which were the posterior chamber intraocular lenses, starting from a single piece to 3-piece. Initial material for the posterior capsular lenses, posterior compartment lenses were PMMA, but then now presently we also use acrylic for the foldable ones. The present day are the generation 6. It is mainly introduced after 1990s. So these are the most popular ones. And not just intraocular lenses, we are using toric intraocular lenses, and we are progressing towards true emetropia. That is, we are leaving this eye in such a state that there is no refractive error left, left, and the target is always emetropia. So over the years, various lenses have been introduced. There were also accommodative IOLs into the picture, which then now better lenses such as monofocal plus came into being, and then extended depth of focus lenses were there, trifocals were there, and currently we are on the continuous range of vision lenses, which give absolutely clear vision at all distances without any side effects of glares or halos. So like Shakespeare says, all the world's a stage and all the men and women are merely players. They all have their exits and entrances. So one man in his time plays many parts and his acts being 7 inches. That is, it is this world is a stage, and I hope after today's class, some of you must have been provoked by this, and probably in the coming years, we see some new developments and new inventions from the upcoming generation as well. Thank you so much.
Thank you very much, Dr. Kanika. That was a very insightful lecture. Just a few comments from you only as to how and where do you feel is the surgery poised in future? And I would request sir also to comment on this. And what is the evolution in the IOLs that we are looking forward to? We have definitely learned a lot from the past and improved upon, but where is the future headed to?
Ma'am, I think the accommodative IOLs which were previously introduced were not very successful, and there were some drawbacks to them. I think in the upcoming future, presbyopia correction and even accommodating lenses should be worked upon more, and there are multiple studies that are going on, and I hope in future there will be some lenses which can actually change shape, and capsular positioning can be changed intraocularly. There are also developments in science where there is a liquid that is being injected into the capsule where that will eventually behave as a lens, and it can accommodate as well. So more of these things are there, and I'm very excited if in the upcoming years, if we get to know that such a thing has been approved and we can utilize it in our practice. So over to you, sir.
Over to you, sir.
I think a very interesting talk, Kanika, and it again just told us and showed us what the developments in science can do. Historically, science really has come in the last 100 years. Prior to that, it was a very gradual meandering of processes. But sea change over the last couple of decades, especially in lens technology, in cataract technology as well. So I think the future is going to be in terms of just the finesse with which these machines will work. There will be more and more of the so-called robotic element that will come in. Cataracts are only going to get softer as we try and take them out sooner and sooner. There will be a greater emphasis on the refractive correction, which actually raises the bar for us as surgeons, because then to deliver outcomes which are predictable and consistent is going to become a challenge. Costs will come down, I'm sure, making these technologies more affordable, and that will increase the penetration amongst our people or all over the world, because cost is a major factor in at least femto laser assisted surgery. On the lens side, you're right. There's going to be injectable lenses. There are going to be light adjustable lenses. There are going to be drug-eluting lenses, cutting down the number of drops and all that. There are going to be lenses with much better optics, less dysphotopsia. As we understand the problems that the lenses create, there are solutions being worked on. So I think overall, exciting future as well. Cataract surgery has already emerged to be, it's the most commonly performed surgery. We know that across the world, and numbers are only going to grow.
That's right, sir. So, carrying forward our discussion, Kanika, where do you think is the past relevant still? So, which are the situations where you think you can still use a cryo, or we do know that yes, there are a lot of situations where we can still make use of ECC, we can still make use of SICS, but if you would like to still bring upon into the attention of everybody that not all past is lost and forgotten, and we must keep evolving upon the past. However, we may need to handhold upon the past and take cues from it whenever we are in a tough situation.
Yes, ma'am. So, like you already mentioned, it is the tougher situations which actually open up our brains more. And it's at those times that we need to apply all the knowledge from our past as well so that we can give a better outcome to the patient. Like you said, ma'am, cryo extraction has been very popular in the previous times, but presently most institutes do not have those equipments. However, if the equipments are available and if there are certain complicated situations where we know the back zonular complex is not going to give a lot of support and there is going to be inadvertently a secondary IOL procedure, for a fast and quicker delivery of the lens zonular complex, we can easily go ahead with ICC. In fact, using cryo extraction technique. Also, there are certain cases such as dislocated and lenses in muffins and other situations where we know that inadvertently we will have to go for a SFIL or a scleral fixated IOL in the future. So we can utilize these techniques from the past if we have access to these machines. ICC is still not, I would not say it is not redundant yet, because we do have situations where we have to take it out. The only thing that we need to make sure is that we do not disturb the hyaloid and the vitreous phase as less as we can create disturbance there so that we don't cause the patient a retinal detachment. ECC, I would say, is still very, very commonly performed in most of the situations where we need to convert our cases, like when there is some complication on table where we need to quickly deliver the nuclear pieces or even the nucleus at times when we notice a PCR and a large PCR, which does have a risk of posterior dislocation of the nucleus material. So converting your phaco incisions to ECC even today is a very good practice, considering it gives a good post-operative recovery to the patient if done properly. So ECC, I would still say, is very commonly performed, ma'am. The only thing with ECC is that one should be well versed with good suturing techniques. Over to you, sir, for the same.
Yeah, I would actually like to listen from sir because he has had most experience out of all. So he'll be able to guide us best as to are these techniques still useful to us in our daily practice?
Good question. I'm not sure if they are actually. I think the point that Kanika made about suturing techniques is fair because that's an art that we are forgetting. Cornea guys still have it to an extent because we do suture tissue, but if you look at the pure cataract surgeon today, he hardly puts a stitch. And so when it comes to that level, it becomes a little tricky in case stitches need to be put. I think the evolution is only going to be forward. These techniques will slowly, literally go into the pages of history. SICS will continue to flourish and thrive, I'm sure, at least for a few decades before we are able to essentially just put in a needle into the cataract and suck everything out, which will also happen. Some enzymatic things will come in which may dissolve the cataract in situ, and we'll be able to just take it out. Then, of course, the utopian ideal of a cataract not being allowed to develop at all. So we don't know when that will happen. So looking into the future, there's lots happening.
So do we have any questions with us, Kritika, for sir or for Dr. Kanika?
Ma'am, I cannot find any questions on either.
We have Dr. Tulika with us. She is our DNB student. Tulika, how intriguing do you find that what you're doing now in the OR is very, very different from what we have been doing in the OR? I mean, we had been doing in the OR in our training times.
Yes, ma'am. It's really intriguing and really fascinating to learn about the history of this surgery and how the many ways people have dealt with cataracts. And it's also a good thing. I think it fascinating mostly to learn SICS well, which can we can use in certain situations where the endothelium is not good, or the bag or the it's more risky, especially for a new surgeon to attempt a phaco. So it's good to have those skills in the bag for such situations. So yes, I'm just inspired really, and to learn better and perform better and give clinical outcomes to our patients.
Great.
So it was very nice class, ma'am. Thank you.
Sir, I think you would agree that the skills of performing an ECC or SICS demanded much more tissue respect, demanded much more skill set. Though phaco is, of course, a beautiful art, but we must not forget that tissue respect is the most important thing when it comes to a surgeon.
I totally agree. I remember when IUL started at the RP Center, I had just become a senior resident. And in fact, about a whole project of about 6 of us was, in a sense, created, where we had a doctor coming in from the Karolinska Institute from Sweden to teach us to do IUL surgery. So he came in and taught us ECC IULs. It was a completely new art. All that we have been doing till then was ICCEs. And so that was a huge change, going from ICC to planned ECCs with a can opener capsulotomy and putting lenses in. Fortunately, the program was supported by large grants from the WHO. We were able to get in lenses free. There was nothing available in India. We were able to even get in with the grant from, I think it was Sweden and Karolinska Elon. So it was a commodity that was in very rare supply. I'm talking 1985. Was it 84? 85. So 85 is when we first did that. And we were able to get BSS from Alcon, which was imported again, because all we had here was ringer lactate. In fact, we did studies showing comparisons of endothelial counts with HPMC versus Helon. We did counts, studies on inflammation and endothelial counts with ringer lactate versus BSS, and between different kinds of lenses. So it was a very exciting stage, and I think we were very fortunate that we were actually in an excellent training institution when the transition was happening. But I was already not in a position to get formally trained when phacoemulsification came in. So that was a sea change as well, with incisions going down, with stitchless surgery coming in. So that was something that I needed to train, and I was in the UK, fortunately, again, to be able to transition there under excellent supervision. Then, of course, things like another, I think, sea change happened about 10 years ago when we stopped giving blocks. So I've been almost 100% topical surgeon for the last more than a decade now. And I think I'm actually much happier doing a surgery under topical than with the block now. So it's just a question of how you train and how you evolve with the times. And I think the whole topic was about evolution. And I think every one of us, even those who are now doing their residencies, they're entering at this stage. But God knows what kind of evolution and evolutionary concepts will come up over the next 3 decades, which will cover their careers. So we'll be long gone, but they will again have the benefit of starting so much ahead. But yes, I think certain techniques one will still need to remember. One of them, very, very important technique, is suturing. It's something that you must know, suturing the cornea, suturing the conjunctiva, suturing the lid, which is, skin, knowing about simple things like Langer's lines, where the incision should be placed. Surgery in the end is aesthetics. It should look good. If it looks good, it will do well too. Yeah, I think, yeah, but very nice. Nice talk, Kanika.
Thank you. Thank you so much, sir, for such an insightful talk. And Kanika, we had a great time listening to you once again. Thank you so much. If we don't have any further questions, can we call it a day?
I think
Dr.
yes, ma'am.
Kritika?
No questions, Dr.
Yes,
Kurtika?
ma'am. No questions on any platform, ma'am.
Any questions that you have in your mind, Kritika?
Ma'am, it was great listening to the history of cataract surgery, ma'am. So there's nothing, ma'am. It's just an evolution. So it was wonderful, ma'am.
So it was a storybook time today for
Yes.
Yes, ma'am.
all.
With
Great.
videos, with pictures. Yes, ma'am.
Yeah. Right. So I think we can call it a day, sir, with your permission.
Yes, of course. I think if there are no further questions, it's been a nice talk, and we'll catch up again with the next session.
Thank
Thank
you,
you,
sir.
Dr. Kiran.
Thank you. Thank you so much.
Thank you so much. Thank you,
everyone. Good
Kanika.
night.
Thank you, Kurtika. And
Thank you.
thanks the whole team.
Thank you.